the proposed Curtin School of Medicine. I've been here for 11 months now, and I must say that the time has been made up of three very interesting and contrasting aspects. The first is domestic, that in coming here I've uprooted my wife and myself from our 5 kids and 5 grandchildren and 2 elderly parents, and that's quite a challenge. We've settled in South Fremantle, bought a house in South Fremantle, and my wife's the project manager for the renovations, so she doesn't worry too much about what's happening with the grandkids. Actually, one of whom just got and accepted a proposal of marriage last week, so that's very nice. The second area is Curtin University itself, and I must say I've been really warmly welcomed here and really enjoy being here. It's a great university and great people to work with. And the third area is medical politics and the politics surrounding the creation of the Curtin School of Medicine, which is very challenging, especially in this run-up to the federal election. This is our medium-term aim, a graduating class of doctors. This is the Gippsland Medical School 2011, and if you use your imagination, you can just see me, the oldest face in the crowd in the middle, waving a bonnet with a yellow tassel on it. So this is the actual class that I brought through to graduation at the Gippsland Medical School, and I must say it was one of the best days of my life. After working with these young people for 4 years, it was a graduate entry course over 4 years, but spending 6 years in developing the course and bringing them through to graduation. So we hope that's what's going to be happening with graduates of the Curtin Medical School in 2020, all being well. Ready to be interns in 2021. But we must remind ourselves that the real longer-term goal is the benefit of the patients that these people will treat and the benefit to the community of Western Australia for setting up a new medical school to fulfil a much-needed role in providing doctors for underserviced areas. I thought I might just be a little bit self-indulgent for a minute or two so that you can see where I'm coming from and just spend a few minutes telling you about what I bring to this job of creating the new medical school. Michael mentioned that it was a long time ago that I did medicine, and I actually find it hard to believe, but this year's the 40th anniversary of my graduation as a doctor. 40 years of medicine, it's very hard to believe. I started out in my practice, of course, as an intern and did a little bit of postgraduate training in clinical medicine, but very quickly got into my interest in medical education and was a clinical tutor at Monash and also a clinical tutor with the family medicine program of the College of General Practitioners back in the mid to late 70s. I worked as a GP in inner suburban Melbourne and as a senior lecturer in community health before doing a second degree in psychology and then specialising in public health and epidemiology, which is my medical specialty and the field in which I've spent most of my time working. And it was in that role as a public health physician that I got appointed as a senior medical advisor to the Victorian Health Department through the 90s, where I worked until the year 2000, finishing up there as Deputy Director of Public Health. I then got recruited to do a different kind of job, which was to administer a big research consortium, an extremely successful one, working with neuroscience researchers, working in fields such as schizophrenia, Alzheimer's disease, Parkinson's disease, and those sorts of brain degeneration illnesses. And Monash then picked me up again in 2006 to help to establish the graduate entry program based in a rural medical school in central Gippsland, which is where I really got the experience of setting up a medical school and finished up as its head in 2010. So I was with the graduating class in 2011 before coming over here last year. The aim is to establish the Curtin School of Medicine because there's a big need for it in this community. The community of Western Australia is relatively poorly off for doctors, particularly in outer metropolitan and rural areas. There's a great need for general practitioners to be working in those areas and a focus also on mental health and aged care. So the proposed School of Medicine aims to fill those needs. It's also important because it will be the only opportunity for students leaving school in Western Australia to go straight from school to study medicine, because the other 2 universities providing medical courses at the University of Western Australia and the University of Notre Dame now only have graduate entry courses. So for a student leaving school, it's a 7-year journey through an undergraduate degree and then 4 years of graduate entry medicine, whereas the Curtin proposal is to have a direct entry undergraduate degree that'll take 5 years for a student to come straight from school. We also intend to target our student selection policies at students from socioeconomically disadvantaged areas and rural areas and Indigenous students, so that we can encourage students to come and study medicine who might have otherwise found it difficult to do so, knowing that such students are more likely to return to work in those areas, which are the areas of most need. And coming straight from where they've been at school and the communities that they've been schooled in is going to facilitate that selective student application policy. It's an important move to establish the Curtin School of Medicine because it will help to redress what is a significant interstate inequity in doctor numbers. There are 348 doctors practicing in Western Australia in effective full-time practice because, of course, some people work part-time. 348 compared with an Australian average of 381. And very importantly, and surprisingly, the Australian Institute of Health and Welfare found in its most recent report that that number is going backwards rather than going forwards, notwithstanding the fact that there's already been growth in number of student intakes and number of graduates in medicine in Western Australia. Nevertheless, despite that growth, the number of practicing doctors in effective full-time practice has been going backwards, not keeping pace with population growth, partly because of changed practice patterns and earlier retirements of doctors as well. If we can produce local graduates from Curtin Medical School, it'll also help to redress this issue of our reliance on overseas trained doctors. Western Australia has a significant proportion of overseas trained doctors in our workforce, and in many ways that's a good thing because those doctors bring different perspectives and different cultural attributes to our society. But the over-reliance on doctors, including doctors who are trained in countries such as Sri Lanka, Nigeria and India, at the expense of those countries, coming here then to provide service not as normal migrants, but as people whose entry into the medical profession here is facilitated, is not really sustainable in the long term, and it doesn't seem fair on the countries that they're coming from. 53% of West Australia's rural doctors are overseas trained doctors, and when we start increasing our number of local graduates, that'll help to redress that. So where are we at with the proposal? Well, we've recently had a restatement of very strong support from the Curtin University Council. The Council's 100% behind the proposal to establish the Curtin University School of Medicine, as is the state government. We've had very recent statements of support from the Health Minister and also from the Premier about the need for another medical school in Western Australia and their support for a Curtin University School of Medicine. It's proving a bit more difficult at the federal government level, however. We did a lot of work last year with the Labor Minister and were not able to get a decision. We were told that the Minister had decided that more analysis needed to be done on workforce needs before any new medical schools would be funded in Australia. And of course, in the run-up to the current election, we've been doing work with both parties to try and convince them that the time is now right to approve the funding and establishment of the Curtin Medical School, but no announcement so far. When we do get a federal government approval, the next step is to get accreditation for the school from the Australian Medical Council, which is an independent body which will undertake accreditation of the medical school when asked to do so by the federal government, but not before. I think we'll be in a very good position to get accreditation at the first try. I've had experience of having a medical school accredited before in Gippsland. I know what it takes, I know what the process is, and we will also be assisted in the process by some input from some of the other university academics, both in this state and elsewhere. Which brings us to the other groups that are involved in our proposal: the Australian Medical Association, the Australian Medical Students Association, and the Committee of Deans of Medical Schools of Australia and New Zealand, the Medical Deans of Australia and New Zealand. They all have a lot in common with what we're trying to achieve, and so at first blush one might think that they'd be in support of it. But in fact, all three of those bodies are strongly opposed to Curtin University being granted a medical school at this point in time. And I'll spend a little bit of time exploring why that might be the case. Of course, one of the key questions is, do we actually need another medical school in Western Australia at all? Clearly, my answer to that question is yes, we do. And it's partly due to workforce shortages. I thought I'd just quote from the Journal of the Australian Medical Association of Western Australia. This is the July edition, last month, current year. For the last few years, it's been well known that Western Australia's population is growing at between 1,500 and 1,700 people a week. This figure is indeed staggering, but the size of the figure seems to be taking some time for people to accept it as fact. In fact, there seems to be a dislocation between the immutable fact of our fast-growing population and our plans for capacity demands in our health system. Anyone living in Perth for more than a few years can attest to how this fast-growing population has impacted on their lives, from the number of cars on the street, the number of students in their children's schools, to the difficulty of getting in to see a GP. Unquote. So you might think from that, and I'll show you another recent quote as well, that the AMA has recognised that the population is growing at such a rate that the supply of doctors isn't keeping up with it, and that therefore we ought to have some more doctors. And indeed, the president of the AMA has made recent comment about the state already being short by between 300 and 500 GPs and how desperately we need more. As well as the actual numbers of doctors, we've also got a maldistribution of workforce. There was a recent report from the Perth and East Metropolitan Medicare Local about disparity between doctor numbers in the western suburbs of Perth and doctor numbers in the eastern suburbs of Perth. A 4-to-1 disparity, 4 times as many doctors per head of population in the western suburbs as in the eastern suburbs. Not too surprising, perhaps. That's where the doctors have been able to choose to live and work, in the more affluent suburbs. It's known that doctors will choose to work and live in places that they're familiar with, where they grew up, where they went to school, where they studied medicine, and also the way in which they were taught medicine influences the kind of practice and where they want to practice. So if we want to try and influence our students to be outer metropolitan general practitioners, which is what Perth most particularly needs, as well as rural practitioners, we should try and select our students from those areas and also train them in areas which are similar to where they'll end up working. So eastern suburbs, Midland, Bentley, sounds like a good place to train our future doctors. There is, of course, a shortage of rural and outer metropolitan doctors, but also a particular shortage in general practice. So our medical school is going to have a focus on general practice. We, of course, can't train general practitioners. That's a postgraduate process. But we can train doctors in such a way that they see general practice as being an interesting, exciting, and preferable career choice. Western Australia has got some unmet health needs, particularly in, as have many other places in Australia, in aged care and mental health, rural health, adolescent health, and Indigenous health, and we're going to focus on those. Here's that other quote I mentioned from the current president of the AMA Western Australia. So the article was about Western Australia paying thousands for fly-in, fly-out health staff just a couple of days ago. Western Australia is spending hundreds of thousands of dollars flying in surgeons, nurses and doctors from as far away as Oman to cover shifts in remote and rural areas. And the president said, by the way, I'm a member of the AMA, the president said, it does not surprise me, and it's going to take time to train more nursing and medical staff for all of Western Australia. And indeed it is going to take time. Even if we got an approval tomorrow, given the AMC, Australian Medical Council accreditation process, we couldn't have a first intake of students until January 2016. It's a 5-year course, so we'd have interns looking for postgraduate training in 2021. My point is, unless we do this quite quickly, we're going to be in a really acute workforce shortage situation. We're already in a workforce shortage situation. So the type of training that we're talking about is a 5-year undergraduate course, 2.5 years based on this campus doing preclinical training and 2.5 years of clinical training. The first half year being largely simulation training, a lot of it based on this campus, and the final 2 years being in the hospitals. There are 4 key themes to the curriculum, which I'll return to in a minute, each one of which has got learning objectives over the whole course, broken down into yearly learning objectives and week-by-week learning objectives that the students have to fulfill. The course here will be partly based on problem-based learning, but it won't be exclusively a problem-based learning course. We'll use problems to illustrate particular scenarios for students that will give them clinical relevance and give the students an opportunity to work together as a team to solve those problems, mainly to stimulate their interest in studying the basic sciences that underpin those problems in the early years of the course before they get out into the clinical years. Clinical placements has been a big issue for the Australian Medical Association. They have made it clear that existing placements for the other 2 universities are very, very tight, that the hospitals are struggling to keep up with student numbers, and therefore it's important that we find appropriate placements for students that don't put too much pressure on places where there are already lots of medical students. And so we're putting in a lot of work with hospitals in the northeastern, eastern, southeastern and southern areas that are not much utilised currently. So from Peel Health Campus and Rockingham Hospital in the south up through the new Fiona Stanley Hospital, for example, the new Midland Hospital, and up as far as Joondalup will be our primary clinical placements. It's very important that we meet the standards required by the Australian Medical Council. The AMC have got criteria for the kind of attributes and standards that they expect to see in their graduates, and we're going to ensure that the graduates from this course are intern ready to start work, but we want them to have a bias towards their eventual career being in general practice. We think that's where the major need is, in the outer suburbs and rural areas of Perth. Of course, for students that want to be specialists in whatever other field than general practice, there's no barrier to that, but we just want to have their mindset oriented towards general practice. The curriculum framework for junior doctors, I say they're CFJD, is what they undertake in the first 2 years of their postgraduate training when they're interns, and we're going to make sure that our graduates are full bottle ready to undertake that curriculum framework. The 4 themes of the medical course as it will be taught here. First theme around personal and professional development, about ethics, the law, professionalism, personal behaviours, personal health and well-being. It's all about the individual becoming a doctor. The second theme is about populations and population health, social health, epidemiology, the place of medicine in society and the interactions between social situation and medicine. The third theme is the scientific basis of clinical practice, all the ologies, physiology, pharmacology and anatomy, applied to clinical issues, and this is where problem-based learning is particularly valuable as a study technique, that you can apply the basic science methodologies to clinical problems even from an early stage of medical training. And then the fourth theme is clinical skills, diagnosing, treating and advising patients. As the course goes through its 5 years, there's more and more emphasis on the clinical skills component and less emphasis on the basic science. Well, we don't yet have approval to run an undergraduate medical degree, so in the meantime, we have been working with a significantly large group of doctors who have been appointed as adjunct staff members of Curtin University to develop material at a postgraduate level for working with doctors who are already qualified and who are looking for the next step. We brought the adjunct professors and other staff together in a think tank on the 25th of March and looked at what are the areas where it makes most sense for us to focus our energies leading up to the eventual accreditation of a medical school, and what should be our foundation departments. Rather unusually for a medical school, we've decided that our foundation department should be in general practice. Normally, medical schools get foundation departments around the preclinical departments of anatomy and so on. Well, this university already has a lot of that material already in place. So our foundation school structure is going to be based on the discipline of general practice. Now, Macquarie University has a very interesting model in place. It has a postgraduate medical school. It doesn't have undergraduate training at Macquarie University. And they have a focus on surgery as one of their key foci for their postgraduate school. My own preference is that we would have a focus on general practice and various issues in general practice. We will be looking at how we can support our adjunct appointments and our own internal staff with a meaningful research strategy, and how we can apply to the federal government for funding for medical research even before we get our undergraduate course approved. And we'll be developing coursework at the postgraduate level, particularly short courses, online courses. And we're already running, and have been for 12 months or more, a master's degree in occupational medicine, which is for doctors only. So in that sense, the medical school is off and running. We do in fact have a master's level degree already running, but the main game is the undergraduate medical degree. So these are the sorts of things that we can do at the postgraduate level before we get our undergraduate degree running, and we've made a start. We'll certainly be looking to increase our share of the National Health and Medical Research Council budget by putting in good proposals for NH and MRC funded research. It's difficult for a university without a medical school to access a fair share of the National Health and Medical Research Council budget. And we hope that the creation of the medical school and leading up to the creation of the medical school will mean that we are able to put in better proposals to the NH and MRC for increased medical research funding. We certainly don't want to be doing our own thing. The university here has a very large faculty of health sciences that Professor Berndt is the director of, the Pro-Vice Chancellor for Health Sciences, and we certainly don't want to be setting up a school that is doing anything other than adding value to the existing schools on this university. So we'll be looking to do interprofessional research and build on the strengths that are already here. The Curtin School of Medicine will have a mission to primarily address the health needs of the local community. We're looking primarily to train general practice oriented people, and so we'll be looking at research that fits that mission. What are our best medical niches given our staffing profile and the sort of work that we want to do? I won't go through them all, but you can see from the list there that we've decided to target a few particular areas of medicine that are well supported at Curtin and that it makes sense for us to be competitive in. Hospital admissions are very expensive. And so one of the things that we want to do is to produce doctors who work in primary care settings and who are confident and competent to work with patients to help them stay out of hospital if they don't need to go there. Hospitals are not particularly pleasant places to be in, as you know. They're also risky places to be in. Things can go wrong in hospitals, infections can occur in hospitals, and so if we can help patients to stay out of hospital, that's a really good thing to do. So one of our foci on producing doctors who want to be general practitioners is to train them in a way that they'll be able to help their patients stay out of hospital. It's estimated currently that 9.2% of all hospital admissions could have been avoided if adequate care had been provided by their primary care providers. That would have saved a lot of money. $3 billion in 2008-9 spent on potentially preventable hospitalizations. But much more importantly than the dollars saved, it would have saved a lot of unnecessary stress, trauma, and potential hazard to the patients that were admitted there. Now, primary care, which is going to be our focus, general practice and primary care, can actually be cost-saving for the health sector. So normally we think about producing a lot more doctors is going to cost the community a lot of money. But one study that was carried out in South Australia showed that the creation of a new primary care service providing care to patients that had previously been inadequately serviced, it did cost $490,000 per annum, but it broke even in 4 years by prevented hospitalizations and the costs of those unnecessary hospitalizations. And not only had it broken even, it had actually returned the setup cost of establishing the service within 7 years. So that's what we're aiming for from our graduates, is to work in those sort of settings with that kind of expertise that will help their patients to stay out of hospital when they don't need to go there. We want GPs, particularly GPs, who have got the confidence and capability to work with their patients in such a way that they don't have to get referred to hospital when it's not necessary. How are we going to select our students to try and make sure that we get the kind of doctors that we need? Well, the first thing is to get out into the schools as soon as we've got approval for our course, which is a course for students straight from school, to get out to the students in schools and make sure that they understand that although we're offering a general medical degree that will be registrable anywhere in Australia and they'll be just as good a doctor as anybody else, we are particularly interested in people that want to be general practitioners and who'll provide services in the community. And that if they already know that they want to be a interventional cardiologist or somebody that does very, very highly specialised surgical operations, although they'll be trained to be an intern anywhere in Australia and capable of undertaking that postgraduate training if that's what they really want to do, that's not our focus. Our focus is going to be on general practice, and that's the kind of student that we want to attract, somebody that can see their career as a GP. Normally, to get into medicine, you need an incredibly high ATAR score, 98, 99. And you don't actually have to be a genius to be a good doctor. I can attest to that. You need to have a lot of commitment, and you need to be good with people, but you don't actually need to be a genius. And so we intend to de-emphasize the ATAR score required to get in. Although I already know that because we'll be the only avenue for students coming straight from school to get into medicine in Western Australia, it's quite likely that the average ATAR score is going to be 99 point something in our applicants, because the brightest and best kids often want to do medicine, but strangely enough they're not always the best people to be doing medicine unless it's highly scientific medicine that they want to do. So we're going to explore selection quotas and look to select a proportion of our students from rural and lower socioeconomic status suburbs, perhaps 50%. We're going to use selection interviews that I became very familiar with at Monash using the multiple mini interview. We'll use regional selection panels to set up interviews with students in their hometowns. And then after they've been selected, we'll appoint panels of regional medical mentors to support students in their hometowns as well. We know that there are particular areas of unmet medical need. We know, for example, that in Western Australia, Aboriginal youth have 4 times the death rate of non-Indigenous youth. And so therefore there's a very important need to focus on that particular type of health problem. We know that health status in rural regions is not as good as in metropolitan regions. We know that Western Australia has a lower proportion of doctors in its community than in the rest of Australia. It also has a low number of medical schools. University of Western Australia and University of Notre Dame, against New South Wales, for example, that has 5 public medical schools and the University of Notre Dame in Sydney. So if you look at it on a population basis, we are a bit underdone in Western Australia. We also have a low medical student intake on a population basis. Latest figures, only 14 per 100,000 of population go into medicine, whereas in South Australia, for example, to be fair to them, they are running a small cohort on behalf of the Northern Territory. It's 22 per 100,000 in South Australia. So on those sorts of figures, we seem to be a bit underdone. And yet we have got the highest population growth rate in the country, 7,000 new people per month being added to the West Australian population at a rate of 3.4% compared with the Australian growth rate of 1.7%. So twice the growth rate of the rest of Australia. So to my mind, it's quite clear that we should have more doctors trained. So why are the medical deans of Australia and New Zealand, the Australian Medical Students Association and the AMA currently lobbying against it? Why do they think it's not a good idea that Curtin University should have a new medical school? Well, they say that the hospitals in Perth cannot provide adequate clinical experience and supervision for students. They're already overcrowded. It's very difficult to find clinical placements for students. So we need to have an answer for that. They say that the internship situation has reached crisis point and there aren't enough internships for postgraduate training of the graduates that are currently coming out, and that problem needs to be solved before there are new graduates coming out from Curtin. Well, I agree with that. There must be adequate, well-supervised internships for people who graduate. We're talking about Curtin graduates needing internships in 2021. That seems long enough to solve that problem, especially given the growth rate of the population over here and the need for hospitals and other healthcare settings to cater for those people. Accredited postgraduate training positions for people that want to train as specialists and general practitioners. Again, that goes back to the timeline for Curtin graduates requiring those positions and the government's intentions and responsibility to create the kind of training positions that are needed. So the conundrum that we're left with at the moment is that most people agree that Western Australia needs more doctors, but we can't train any more doctors because we haven't got enough doctors. So we've got to do something to break that nexus, and I think that we've got some answers. We will in fact recruit and train new clinical supervisors for students from doctors in suburbs that have previously not been much engaged with the training of medical students because they've been geographically in the wrong place. They haven't been in the University of Western Australia or Notre Dame University catchment areas. We will use currently under-studented general hospitals in that northeast through to southern catchment area. There will anyway there is a planned 30% increase in public beds by 2020, which means there'll be a lot more patients there for students to get experience with. We will be using a more innovative training model, doing more of the training outside of hospital to make it more appropriate for modern practice, where a lot of community practice, in fact, is done outside of hospitals, particularly general practice and aged care, which are the growth areas and the important areas requiring our doctors. We'll use a lot of simulation training, not exclusively, but we'll prepare students more for the clinical encounters that they'll have in hospitals and general practices by using simulation training appropriately early in the course. At any rate, we're talking about putting clinical students into the healthcare system in 2019. There's going to be quite a lot of growth in the system to cope with more student numbers by then, and interns by 2021. There's been a lot of growth already from the other two universities, and that growth is continuing. But they're the very people who, by 2021, will be able to be the qualified supervisors of our interns. I just wanted to spend a moment talking about our plans at Midland. There's a new hospital being built at Midland. It's going up very rapidly. The Premier of this state has promised to fund a new facility adjacent to that hospital, which will provide for Curtin University to train its medical students and other allied health students in affiliation with the Midland Hospital. It's a terrific coup, really, to be able to do that. And I anticipate that Curtin's modus operandi of interprofessional training will really enable that facility to be one of a kind and to be a standout for training in this state. So the Midland campus is likely to open in 2015-16. There won't be any medical students there. So we'll be able to get the thing going with the other allied health students and have the facility running for medical students to participate in it when we get our first clinical medical students through in 2018-19. So I'm really hopeful that it works. I'm really hopeful that the message gets through to the federal politicians that this is a good thing to approve. Don't leave it. Let's do it now. and let's make sure that we produce the kind of graduates that the community needs and can really make a contribution to people's health. So ladies and gentlemen, thank you very much for listening to me, and I hope that I've brought you up to date with where we're at with our plans for the Curtin Medical School. Thank you very much for listening.